So hi guys and welcome to this session. So in this session in the pediatrics we'll be discussing about general pediatrics that will be very helpful for your exams and I will be covering each and every topic related to the general pediatrics in this session. So general pediatrics is very important, like you will be getting definitely a questions in this. Please go through this. Whatever I will be teaching is an MCQ. So please go through these standard values very carefully. Okay, let's begin our discussion. And if you take this general pediatrics, you all know neonate. So what do you mean by this neonatal period is like 0 to 28 days of life. 0 to 28 days of life is known as neonate. So this neonate, it is divided into two types, that is early neonate and late neonate. Early neonate is nothing but the child which is born from day 1 to 6th day of life. Okay, 1 to 6 days is early neonate and rest is nothing but late neonate. From 7 to 28 days of life is late neonate. Okay, and these newborns, according to the gestational period, they have divided into three types: term, preterm and postterm. Term is nothing but if the baby is got delivered between 37 weeks of gestation to, yes, less than 42 weeks, that is your term gestation. And what do you mean by the preterm? If the baby is delivered less than 37 weeks. Okay, and what do you mean by the postterm? If they are delivered greater than or equal to 42 weeks of gestation. That is about term, preterm and postterm. And according to the birth weight also, the baby are divided into three types. Very important: low birth weight babies, very low birth weight babies and extreme low birth weight babies. So normal baby weight is 2.5 to 4 kgs. Okay, if anything which is greater than 4 kg, that is macrosomia, no? And large low birth weight baby. So what is the cutoff for low birth weight? Any baby whose weight is less than 2.5 kg, that is low birth weight baby. Okay, and what do you mean by this very low birth weight baby? If the baby weight is less than 1.5 kg. And extremely low birth is the baby weight whose weight is less than 1 kg. Okay, these are all the according to the birth weight babies have divided. And next, according to the gestational age and birth weight, the babies are divided into SGA, AGA and LGA. SGA is nothing but small for gestational age and SFA is nothing but small for date. Both are same. SFD is nothing but small for date babies. SGA is nothing but small for gestational age. If I put the baby's birth weight in this graph, no, like there will be two chord, that is 10 less than 10 percentile, no? If the baby's weight is less than 10th percentile, so that is known as small for date or small for gestational age baby. So what do you mean by this appropriate gestational age? 10 to 90th percentile. Okay, and large for date is nothing but which is greater than 90th percentile. Okay, so this is about on the basis how the babies are divided. And some normal values you should be know. What is the average length of a baby is like 45 to 50 centimeters. Okay, and what about the head circumference? 33 to 35 centimeters. Okay, chest circumference, CC, is nothing but chest circumference. So how much? 32 to 30, sorry, it's like 30 to 32 centimeters. This is about 30 to 32 centimeters. Okay, and upper segment is to lower segment ratio at birth is, upper segment is 1.7 is to 1 and lower segment is 1.9 is to 1. Okay, these are all the ratios. And what is the normal heart rate of a newborn? 110 to 160 beats per minute. Okay, and what is the normal respiratory rate? 40 to 60 per minute. And what is the normal blood volume? Tell me in an term babies, it's 80 to 90 ml. In preterm babies, it's 90 to 100 ml. Okay, these are all the normal blood values. And what about this? You should always put the neonate in supine position. It is yes or no? Tell me. Yes, you should always put the neonates or newborns in the supine position. Yes, this is absolutely true. Don't put the newborns in prone position. Why? This leads to SIDS. What do you mean by this SIDS is sudden infant death syndrome. Okay. Please always put the babies in supine position, not in prone position. And what about normal urine frequency? How much time they will pass? 6 to 8 times in 24 hours. Okay. So how much dose of vitamin D you are going orally? 400 international units per day. These are all very important. They have been asked. So what do you recommend, or if the mother will ask like, when should I bath my baby? Please tell the mother until or unless umbilical cord should fall. After that only bathing is initiated in the baby. Before that, you are not in, after the newborn the baby, the bathing is not required, not at all required. No. So like you should tell, can be postponed. Bathing can be postponed. Yes, why? Till the umbilical cord will fall. Till the umbilical cord will fall. Until then, bathing should be postponed. So normally umbilical cord will fall on 5th to 6th day of life. Okay. So these are all about some general topics. And now IUGR babies, no? Like intrauterine growth restriction, no, not retardation, it's restriction. IUGR, intrauterine growth restriction, okay, not retardation. So this IUGR basically it is divided into two types: symmetrical IUGR and asymmetrical IUGR. So what do you mean by this symmetrical IUGR? When does it occur? It occurs in early pregnancy. Okay. So asymmetrical IUGR, when it occurs in late pregnancy. So early first trimester. Okay. And what are all the causes over here is genetic causes, or it may be torch infections. So here asymmetrical IUGR is mainly due to maternal causes, or it may be UPI, uteroplacental insufficiency. UPI is nothing but uteroplacental insufficiency. Okay. And what about number of cells? Number of cells will decreases in symmetrical IUGR. Okay. So here what about the number of cells? Here cells will not decrease, cell size will decrease. Cell size is decreased over here. Okay. And next, what about weight, head circumference, length? All the parameters are equally affected. Okay. Weight, height, length, everything are equally affected. And what about over here? Tell me here, weight is more affected. Weight is more affected. Okay. Then all other parameters such as head circumference and length. Okay. And what about this ponderal index is used in IUGR? Very important formula. Ponderal index, what do you mean by this ponderal index? Is you are measuring the weight in grams and divided by ponderal index, that equal to, in the numerator weight in grams and in denominator length in centimeter cube. Length in centimeter cube into 100. Okay. This is about ponderal index. So if I calculate this ponderal index for the symmetrical IUGR baby, like it is greater than or equal to 2 here, greater than or equal to 2 in symmetrical. In non-symmetrical it is less than 2. Okay. So what about this which is prognosis is very bad. So here head circumference, everything is involved, but here head circumference is not affected in asymmetrical IUGR. So that's why head is completely fine. That's why like all the structures are not affected. So that's why like here you will get good prognosis. Good prognosis. So here it is, prognosis is bad prognosis here, okay. And how do you treat? And it has, and the studies have been shown that antiplatelet agents, they can decrease by 10%, okay. If the mother will use antiplatelet drugs, there is then chances of decrease of the symmetrical or IUGRs especially by 10%. And if the mother, if you give the protein supplementation to mother, and there is a chances of reducing IUGR by 30%, okay. And what about the vitamin C antioxidants such as vitamin C and vitamin E, there is any role? No, there is no role in IUGR. This they have been asked. So which is not, name the, if there is any role between this vitamin C or vitamin E in IUGR, there is no, definitely there is no role in IUGR. There is no point of giving this vitamin C or vitamin E, okay. And this is about IUGR, very very important. And next, coming to the weight loss. So like we all know that term babies, they will lose us 10% of their total weight in 5th to 7th day of a life. A mother has brought a child to an hospital, and she is telling that my child is lose the weight, and she is very tensed about what are all the, why it is actually happened. It is a normal physiological process, and tell that the mother, and they will regain by day 10 of life, okay. And what about preterm? How much weight loss? Physiological weight loss. Physiology is nothing but, that is not in our control. No, physiology is something that is occurring naturally, that is known as physiological. In term babies, there is a 15% loss in 7th to 10th day of life, and when they will gain? By day 15 of life, okay. This is about physiological weight loss. And neonatal sepsis, very important. If they ask you which is the most common cause of neonatal sepsis, and acetobacter, or like everybody will be telling, plus please go through, like different books are having different answers, like acetobacter acini and all, and Klebsiella. But I have referred to most of the books, and most of the books they will be telling this Klebsiella is the most common cause, and it's up to you. But until my point of view, Klebsiella is the most common cause for neonatal sepsis. It is a bit controversial question, and not Acetobacter acini, and you can go by through Klebsiella, okay. And what is the earliest feature if the baby is having this neonatal sepsis? So what is the earliest feature you will get noted in the baby is, the baby will not eat food properly, or poor feeding, decreased poor feeding, okay. And initial investigation, what you are going to do is sepsis screening, okay. And what is the most effective method to prevent neonatal sepsis? Very very important, that is hand washing. Hand washing for until how many times? Until 2 minutes, okay. This is about neonatal sepsis. And neonatal sepsis are divided into two types: early onset sepsis and late onset sepsis. So what do early onset sepsis? So here there is no controversy, it's caused by GBS, nothing but group B streptococci, okay. Group B streptococci will leads to early onset sepsis. So when it occurs in the first 72 hours of life, like why it occurs? If there is any infection from the maternal genital tract, that leads to early onset sepsis. And late onset sepsis is after 72 hours, and that is in the environment. No, if the baby is having in the ward, if the ward is not clean, and if after delivery, after 72 hours, if the baby gets the infection, that is about late onset sepsis. So this is a late feature, okay. So this is about early onset sepsis and late onset sepsis. And how do you do the test? Some septic screening, sepsis screening test is done So here what are you going to see? Like you are going to see the three WBC components, that is TLC. So total leukocytic count is less than 5,000 and neutrophilic count ANC, that is less than 1800. Here less than 5000 and here less than 1800. And IT ratio is like a total neutrophilic ratio if it is greater than 0.2, and CRP, C cell reactive protein, is greater than 1 mg per dl, and if you ESR value it is greater than 15 mm. So like until or unless now, like no questions have been asked from this, but from this any of the score from these that is greater than or equal to 2 is positive, then you can tell the baby is having this neonatal sepsis. If any of this, if the both the values are true about the data, and even the baby's leukocytic count will come less than 5000, and if neutrophilic count is also less than 1800 and the total neutrophilic count is greater than 0.2, then you can tell the baby is suffering from neonatal sepsis. Okay, so this is about neonatal sepsis, very very important. So how do you prevent? Hand washing and maintaining the proper sterility. And next is neonatal hypothermia, very important. So what is the normal temperature in a newborn? Normal axillary temperature is 36.5 to 37.5 degrees centigrade. So if there are like conditions, no, mild hypothermia, moderate and severe. If they ask you like mild hypothermia, it is also called cold stress. So what is the cutoff? 36 to 36.4 degree. You check the baby temperature and the temperature falls under 36 to 36.4 degrees centigrade, that is known as mild hypothermia or cold stress. It has been asked in your exams. So after my classes or like after our classes, please go through the MCQs carefully. Like definitely will be able to solve most of the MCQs which are related to the pediatrics from these rapid revision courses. Okay, and what about this moderate? If it falls between 32 to 35.9 degrees centigrade, that is moderate wala, and severe is less than 32 degrees centigrade. So these are all about criteria of hypothermia. And by this touch method, this is known as touch method, like you are going to see the abdomen and palms and sole. Abdomen is also warm, palms and soles are also completely warm, then there is no, the baby is having no hypothermia, that is normal. Abdomen is warm and palms are cold, so then the baby is having this mild hypothermia, that is also called cold stress. Okay, and abdomen is cold and palms and soles are also cold, then the baby is having this hypothermia. Okay, so this is about touch method which is used. So there is a brown fat. So what do you mean by this brown fat? Like there is lipid deposits which are rich in mitochondria. Okay, so this is about, so we all know where the brown fat is present. Brown fat is present in the nape of neck, interscapular regions. Okay, nape of neck, interscapular regions, axilla, and in groin regions, and above the your adrenals and all. No, so this is the location where the brown fat is present. And newborns do not shiver because like they will be having this brown fat. No, non-shivering thermogenesis is present in the newborns. And next, one more important condition, that is cephal hematoma versus caput secundum. So what do you mean by this cephal hematoma? Is collection of blood. Hemat is something which is related to the blood between the bones and periosteum. Suppose imagine this is the periosteum. Here the blood is collected, that is below the periosteum, that is known as cephal hematoma. And caput secundum, what do you mean by this? Caput secundum is swelling or It is also known as edema in scalp regions. No? If you find the edema or swelling in the scalp regions of the baby, that is known as caput secundum. Okay, and this is the periosteum, and the swelling will occur above the periosteum, that is caput secundum. Okay, and here whether it crosses the midline or not, hematoma, no, it do not crosses the midline, or it is also called the suture line. So what about this? Yes, it can cross the suture line or midline. And why it is occurring hematoma? Because traumatic delivery, traumatic, if there is a traumatic injury or instrumental delivery. Okay, so here tell me, so what is the cause for caput secundum? If the head of the baby, so by delivering the baby's head, no, in we'll be using some instruments, no, like forceps and all. So that leads to hematoma. If the head of the baby is stuck in a same place, is stuck in a long time. If the head of the baby is stuck in a long time, that is known as caput secundum. Okay. So which is associated with the jaundice? This is associated. Hematoma is associated with the jaundice. Okay. And what about the period from where it occurs between like 5 to 6 weeks, and it will disappear after 5 to 7 weeks, and it will disappear like 48 to 72 hours. Okay, this is about cephal hematoma and caput secundum. So it is like 5 to 7 weeks, it disappears, 24 to 48 hours of in birth. Okay, sorry, it is like 48 to 72, 48 to 72 hours. This is about cephal hematoma and caput secundum. And very, very important for your exam, Apgar score. Look at the scores carefully. In Apgar, A stands for appearance, pulse, grimace, activity and respiration. Okay, so remember, respiratory rate is not an component of Apgar. I am not, respiratory effort you can see, but respiratory rate is not there in Apgar. Respiratory effort is present, but rate is not there. So most of the students, they'll get confused over here. And look at the scores. Score 2, score 1 and score 0. So if the baby appearance, by looking at the baby after the delivery of the baby, you just saw the baby is completely pink and all the completely pink, then you are going to give the score 2, that is fine. And you find that like whole head, body is pink, but extremities, no, extremities are blue, that is known as peripheral cyanosis, then you are going to use score 1. If the baby is completely blue, all the points, so look at the diagram carefully, this is a very beautiful diagram, all the body parts is completely blue, that is completely cyanous, then you are giving to the score 0. Okay, then what about the heart rate? If the heart rate is greater than 100, you are going to give the score 2. If the heart rate is less than 100 beats per minute, or pulse rate or heart rate, then you are going to give the score 1. If the baby is no pulse is not at all functioning, score 0. 0 is very bad score. Okay, and grimace is nothing but an how the baby will cries and activity, whether it is active or not. So like baby is cries and it pulls us away, then you are going to use score 2. If the baby grimace or weak cry, grimace is present or it is weak cry, baby cries properly, then it is like score 2. If the grimace is present or weak cry, that is score 1. Not at all cry, no response, no cry, that is score 0. If the and what about activity? There is an active flexion extension, baby is go flex the hand and extend the hand, so then it's like completely fine, that is about score 2. And if the baby has only flexion but there is no extension, that is known as score 1. You are going to give the score 1. If not at all moving, score 0. Okay. And like What about respiratory rate? Respiratory, baby has having very strong cry, like respiration is strong cry. Okay, the baby is crying very good, then that is like you are going to give score 2. And slow and irregular respiratory effort, that is like score 1. If there is not at all breathing, baby is not at all breathing, then you are going to give score 0 over here. Okay, respiratory rate is not a component of apgar. So remember, apgar is not a diagnostic score, it is a prognostic score. It is used to know the prognosis of the baby, and it is not used as a diagnostic, it is not used to diagnose the baby. So this is an prognostic score. Okay, and when you are going to do the apgar at 1 minute, at 5 minutes. Okay, so you are going to do the apgar, and if your apgar score is less than 3, then you are feeling very sad, baby is very less. No, it is an it indicates very bad score, severe. And if your apgar score is between 4 to 6, then what you are telling, the child is moderately depressed, and you need an airway clearance. How do you clear the airway? By through suction. Suction may be needed in 4 to 6. And if your score is between 7 to 10, then it is completely fine. Okay, you are going to laugh. Baby is going to laugh over here. This is a completely good sign. Baby is completely fine. Okay, so this is about scores of apgar score is very important. Please go through the table very carefully, then it is will very helpful for you. And next, hypoglycemia. If anybody asks what is the cutoff for hypoglycemia, so, like hypoglycemia, tell me. The blood glucose level in the baby or plasma glucose is less than 45 gram per dl, then that is known as hypoglycemia. So what are all the clinical features you are going to do? First, most common clinical feature is jitteriness, or tremors. You can find this jitteriness or tremors in the baby. And next is seizures, and next is lethargy and poor feeding. Okay, these are all, like there are more causes, electrolytic imbalances also, like it like hypoglycemia or not, like there will be lot of causes, but most common cause is like jitteriness and seizures. Okay, and how do you manage? Management is very important. Please look at the diagram carefully, or this whatever I am going to give. If the baby is symptomatic is, which I have mentioned above this, like baby is having the symptoms of an hypoglycemia, then what you are going to do is you are going to give IV dextrose. Okay, at how much? 2 ml per kg, the two bolus. Okay, you are going to give bolus. After that, you are going to give IV dextrose in infusion form at the rate of 6 ml per kg per minute. Okay, so this is the how do you treat the hypoglycemic baby. If the baby is asymptomatic, so you are going to treat the baby based on the blood glucose level. If the blood glucose level is less than 20 mg per dl, and if the baby's blood glucose value will falls under 20 to 45 mg per dl, then how much you are going to give? This is like 6 ml per kg per minute. So how? Infusion form. Okay, and here what you are going to do, if the baby is 20 to 45 mg per dl, tell the mother to proper breastfeed. So like you have to give the oral feeds to the baby. After that, giving the oral feed, recheck the blood glucose. Okay, after like 30 to 45 minutes. After that also the blood glucose value is less than 45 mg per dl, then give baby same 6 ml per kg per minute. So you are going to infuse the IV dextrocertain 6 ml per kg per minute. Okay, this is the treatment of hypoglycemia. Very very important this table. And next is very important neonatal jaundice. So neonatal jaundice, what is the criteria? Total serum bilirubin, how much? It should be greater than 5 gram per dl. Okay. So you are going to tell the baby is having this neonatal jaundice. Neonatal jaundice, basically they are divided into two types. One is physiological jaundice and pathological jaundice. And physiological jaundice, remember, they never appear in first 24 hours of life. Pathological jaundice, this is the jaundice, they may appear in first 24 hours of life. Okay, so this is about physiological and pathological jaundice, first point. And next, what kind of an bilirubin you will find over here? Unconjugated. So can you tell me, like anybody, like which is the most common dangerous hemoglobin, unconjugated or conjugated bilirubin? Tell me. So we all know unconjugated bilirubin is more dangerous. Remember what I was explaining here is like in physiological jaundice, unconjugated bilirubin is more. So like it should be very dangerous. No, but the body has this mechanism. If the baby comes this physiological jaundice, the body has the mechanism to overcome from the unconjugated bilirubin. So that's why like there is no staining of palms and soles in this. Okay, so palms and soles are not stained in physiological jaundice. And what about CNS? There is no CNS is involved. Okay, so what is the treatment? Nothing. Treatment is self-limiting. So remember, for which jaundice you are going to treat, that is your pathological jaundice. Okay, and what kind of bilirubin? Opposite, ulta of this, that is your conjugated bilirubin. So what it is going to stain? Yes, it is going to staining of palms and soles. Okay, and what is involved? Brain is involved. Definitely brain is involved in this. So that's why treatment is needed. So now we all know why. So in which jaundice the treatment is needed? That is your pathological jaundice. Okay. So how do you treat? By through the condition known as phototherapy or DVT, double volume exchange transfusion. So first thing is phototherapy, very very important. So which lamp is used? Remember, LED lamp is used. Then CFN. Okay. So what kind of light is used in phototherapy? Blue green light. And what is the distance from the light to the baby is 30 to 40 centimeters. So what is the wavelength which is used? So everything is important for your exam. Wavelength 460 to 490 nanometer. This is the wavelength. Okay. And mechanisms, which is the most important mechanism, structural isomerization. So what will be happen over here is your unconjugated bilirubin is converted into lumirubin. So when it converted into lumirubin, it can be excreted from the body. Okay, and what is this? This is the most important step. That is structural isomerization. And what about photoisomerization? Z isomers are converted into E isomers. And last step is photooxidation. If phototherapy, doesn't work, then you will go for DVET, sorry, like double volume exchange transfusion. So what you are going to do is you are completely removing the baby's blood and you are putting the fresh blood to the baby. So suppose imagine, so how much amount of blood you have to take for this exchange transfusion is, so we all know like in term baby blood volume is 80, no? Now I have taught you know in earlier slides in term baby. So what is the amount of blood that is needed for exchange transfusion into 2? That is 160 ml per. So this is the blood that you have to use for this exchange transfusion. So what are all the indications? So like cord hemoglobin, in the cord hemoglobin is less than 10 gram per dl, and cord total serum bilirubin should be greater than or equal to 5 mg per dl, and rate of rise in total serum bilirubin that is greater than 1 mg per dl per hour. These are all the conditions. So where you are going to use this exchange transfusion. And some like this is the very important like phototherapy cutoffs they have been asked, like for a preterm babies. Remember preterm babies. If the when you are going to give the phototherapy, if the blood this jaundice level is between 5 to 6, and here it is like in 28 to 31, 6 to 10, 32 to 34, 10 to 12, at 34, 12 to 14. Okay, so if what about exchange transfusion? When you are going to do this exchange transfusion in the preterm is, if this bilirubin like total serum bilirubin is 5 to 6 gram per dl, no, so like you add 555 to it. So this is the for exchange transfusion formula is phototherapy cutoff plus 5. So for 5 if I add this I will get something like 10, no, so 10 to 11, or like for 6 if I add like 5, 11, no, so this is the, so 6 plus 5 is 11, so this is then where you are going to use this, and 6 plus 5 is like something 7 8 9 10 11, and it's like 12, and like add 555 to this, so you will get these values. For phototherapy if you add 5 you will get exchange transfusion values. So this is about preterm. And in term babies, so this is very important. At 24 to 40 hours, if your phototherapy, you are going to start if the serum bilirubin level is greater than or equal to 15. At 48 to 72, it's like 15, 18, 20. 15, 18, 20. Greater than or greater than. And exchange transfusion, when you are going to do, look at the hours over here. It is greater than 20 mg per dl. Okay. And what about this? It's like 25 mg per dl. Okay, so these are all about phototherapy units and how you are going to. So here it's mg. Sorry, this is in grams. This is 5 mg per dl. Okay, so this is about neonatal jaundice. So how you are going to treat and all. So treatment aspects. So how this is about neonatal jaundice and phototherapy. Very very important phototherapy. Like what are all the photo? So what is this? Tell me. This is an phototherapy machine, no? So look at the light. This is the blue green light. This is a blue green light. So what distance I taught you know 30 to 40. Wavelength 460 to 490 nanometers. So which I have written over here. 460 to 490 wavelength. So can you tell me what is this? This is an transcutaneous bilirubino bilirubino bilirubinometer TCB. Okay, So this is like if you put on the baby's body, no, like meter, look at this. So it will tell you the how much jaundice is present in the baby. No, this is about TCB, transcutaneous bilirubinometer. Okay, so this is about very important IBQs. You may get these image based questions in your exam also. And Kremer's rule is used. So very important, like Kremer's rule, they have been asked for this neonatal jaundice. So in this stage one is nothing but head and neck. Okay, so the bilirubin value is 5. And the stage 2 is nothing but chest, from this chest to upper part of an abdomen. So the value over here is 10. Okay, and from here, like this is the where stage 2 will end, from this lower part of an abdomen to the thigh. So remember, this is on zone 3. So here the value, if your value comes at falls under 12, it is zone 3. And zone 4 is nothing but your lower limb plus upper limb. Look at this very careful. I will zoom it. 4 4 4 4 4 4. No, so if the value is between 15, so this is the baby is having the jaundice. And palm and soles, the value is 20. Okay, so these are all about very important values that you have to keep it in your mind. Kremer's rule is very important. Zone 1, I taught you, know, head and neck, the value is 5. Between chest and upper part of an abdomen, the value is 10. And lower part of an abdomen to the thigh, 5, 10, 12, 15 to 20, lower limb to upper limb. So these are all very important Kremer's rule. Like this you should go very carefully. So I have simplified the diagram, like head and neck 5. From this chest to upper part of an abdomen, that is zone 2, that is 10. Like zone 3 is nothing but lower part of an, if your abdomen to the, until your thighs, that is your zone 3. That is the phototherapy value over is there is 12. And like look at this, like lower limbs, all your limbs, lower limbs plus upper limbs, so that is the jaundice value is 15. And palms and soles are 20. Okay, so this is about Kremer's rule. And next, very important, that is types. Unconjugated bilirubin, where you will find, and conjugated bilirubin, where you will find. Remember the mnemonic unconjugated, it's like UGC. Gilbert syndrome and Kriegel-Nagar syndrome, Gilbert and all know. In Gilbert, what will be happen is your UDPGT. We all know UDPGT is responsible for converting this unconjugated bilirubin into conjugated bilirubin. No, here UDPG activity is lost or UDPGT is absent. Okay, so this is about Gilbert. And Kriegel-Nagar, UDPGT is present, but it is present in mild quantities. That is your Kriegel-Nagar. And next is like Dubin-Johnson. So conjugated values is nothing but DR. Okay, DR is the mnemonic over here, doctor. Like Dubin-Johnson. Here what is there? Like MRP2 values is decreased. So that's why you will get black liver. Okay, and rotor, how you can differentiate? There is no black liver. Okay, so this is the how you can differentiate, like Gilbert, conjugated bilirubin, Dr. Dubin Johnson. So best black liver and non-black liver. Okay, and next is like breastfeeding jaundice and breast milk jaundice. Okay, whatever I am telling is very important. So they will be keep on asking. So if you study the pediatrics for any exams, these topics are must. You should know. Like breastfeeding jaundice, tell me which is, this is more common. And breast milk jaundice is rare and this is severe. Okay, and what about risk? There is no risk of CNS damage. There is no risk of CNS damage. Here they can cause CNS damage, and here they can cause bind. What do you mean by the bind? Bilirubin induced neurological disorders. I will write it the full form. They may ask you bilirubin induced neurological disorders. Okay, this is about bind. So when it is going to time, here it's first week. So here is second week to fourth week. So what is the cause? Inadequate feeding. The mother is not feeding the baby, then you are going to get this, no? So why it is occurring? If the mother is not feeding, dehydration. Dehydration leads to hemoconcentration, no? Hemoglobin concentration will, whenever hemoglobin concentration will increase, then automatically jaundice level will also increase in the newborn, okay? And there is, if the feeding is occur and like dehydration, like if the stool volume is also get decreased, that also leads to increased hepatic circulation, that contributes to jaundice in a baby. So what is the cause for breast milk jaundice? Tell me, what is the cause for breast milk jaundice? Is the substance that are present in the breast milk, no? There are some substances that are present in the breast milk which causes the jaundice, that is known as breast milk jaundice. So such as like beta gluco beta gluconodides and free fatty acids, okay, pregnenolone and diol, these are all the components that are present in the breast milk, they will cause the jaundice. So what is the treatment? Increase the feed. Okay, here also breast milk jaundice, you have to stop? No, you should not stop, you should continue the feed and give the phototherapy or exchange transfusion. Okay, these are the treatments. You should not stop the breastfeeding, remember that one. And hypoxic ischemic encephalopathy, like let me discuss some of the neonatal seizures, very very important. So the major objective is like in one slide I am trying to explain all the important topics, so that will cover 95% of your MCQs. Okay, so drug of choice for neonatal seizures is phenobarbital. And which is the most common type of seizures in a newborn? Subtle seizure. Okay, so what is the most common cause of seizures in a newborn? HIE, hypoxic ischemic encephalopathy. HIE is nothing but hypoxic ischemic encephalopathy. Okay, so what is the cause? Like electrolyte imbalances. There are a lot of electrolytes such as decreased sodium, decreased glucose, and all. Very very important. B6 deficiency, that is pyridoxine. Pyridoxine deficiency, it also leads to the seizures, that is refractory seizures, no? Very very important. Pyridoxine deficiency leads to seizures in a newborn. Very important, like this have been asked multiple times. Name the vitamin that leads to the seizures in a newborn. Pyridoxine. Okay, and tell me like which is the best type of an seizure, which has best prognosis? Best prognosis, that is focal, and worst is myoclonic. Worst is myo. W is the worst and make ulta of this yum. That is myoclonic seizures is the worst. So how do you monitor the baby in the bedside if the baby is having seizure or not? Is you are going to do this EEG, that is like amplitude integrated EEG. Amplitude integrated EEG. Okay. So next is HIE. Like in HIE, one staging is used, that is Sarnat and Sarnat staging. Okay, Sarnat and Starnat staging, you are the staging which you are going to use in HIE. So like stage 1, stage 2, stage 3. Stage 1 is nothing but mild, moderate and severe. Okay, like until now question has been not asked, but you should know, like in mild it's like everything is fine, hyperactive, overactive. Moro reflex is also present in the stage 1, mid-ray system, and no seizures. This is very important. Okay, and in moderate, very very important is seizures is present and rest is like the child will become little weak, lethargy, mild hypotonia, weak and all. But very, very characteristic feature is common seizures. Okay. So here stage 3 severe, the patient or child will be in the coma, flaccid and absent. So whichever mark I have put in, please remember, you can definitely, this is a specifically you will see in stage 1, stage 2 and stage 3. Okay. HIE, like Sarnet and Sarnet staging is the staging that is done for HIE babies. Okay. And like breastfeeding, exclusive breastfeeding should be done until for 6 months. Okay. So nothing you should be given to the baby. Like what about the signs of good attachment? No, like if you this is very, very important. Lot of questions have been asked from these 4 points, so I will explain each and every point. Like breastfeeding, we should know each and every topic. Like what is the signs of good attachment is the baby's mouth should always be wide open. No, like the baby's mouth should be always wide open, and the baby's chin should touches the mother's breast. Okay, baby chin touching the breast, mouth should be wide open, and lower lip is everted. Look at this, which lower lip is everted. Everted is nothing but out, not inverted. This is everted, that is outward. So examiner what they will do, no, in terms of this lower lip everted or outward, the examiner they will put inward. That is wrong. Okay, lower lip should be always everted or out. And mother's upper areola should be more exposed. Okay, mother's upper areola should be more exposed, not lower areola. Keep this point is also in your mind. Mother's upper areola should be more exposed, not lower areola. The examiner will put ulta, lower areola should be more exposed. Wrong, mother's upper areola should be more exposed. Okay. And coming to the signs of good attached position, the entire body of the baby should be well supported. Not only like mouth should be, head or mouth should be supported, like whole body should be well supported. Like occiput, shoulder, buttocks, they always should be lie in the same line, and baby should be turned towards the mother, not only the face. No, and abdomen of the baby should touches the mother's abdomen. These are all the signs of good position, but this is very important, good attachment. Okay. And next is like contraindications of breastfeeding. So there will be fetals and mother complications. If the fetus is having this lactose intolerance and galactosemia, so then you are going to contraindicate the breastfeeding. In mother, tell me what you are going to do. There is absolute contraindication and relative contraindication. In absolute contraindication, mother on chemotherapy or radiotherapy, this is absolute contraindicated. Relatively, like maternal HIV or TB. Okay. So storage of breast milk, very important. If you keep the breast milk at the room temperature, you can keep until 6 to 8 hours. In the refrigerators until 24 hours. In freezer 3 months. Okay. This is about storage. And composition, breast milk is highly composed of water, that is 88% of breast milk is composed of water, and calories 67 kilocalories per 100 ml. And carbohydrates is, this is more in breast milk when compared to the cow milk. Carbohydrates are more, such as like lactose, that is 7 grams per 100 ml, and fat 3.5 grams per 100 ml. So one substance that is present in the breast milk, that is known as DHA, docosahexaenoic acid. So this is responsible for CNS development. Okay, and some infective factors are also present, that is immunoglobulins such as IgA, IgM, and IgG. And in breast milk, para amino benzoic acid is present in the breast milk, so that will prevent from malaria. Lactoferrin E. coli and bifidus factor E. coli, and this bile stimulated lipase, tell me, like giardia and entamoeba histolytica. Okay, and next you are coming to the compositions, like what are all the compositions that you are find like in the colostrum, no, like these are all the compositions. And next, colostrum. So what do you mean by this colostrum is, first 72 hours of milk is known as the colostrum. Colostrum is thick yellow color, no, and it is rich in immunoglobulin A, fats, and phagocytosis. And but lactose is less. Very, very important. Lactose is less in colostrum. And transitional milk is nothing but the milk that is come from 7 to 2 hours till 14 days. That is your transitional milk. Most of the students, they will confuse with fore milk, hind milk and all, no. And here fat is less, proteins is less or like very less, and lactose is increased. But lactose is more in mature milk, and rest of this fat, protein, they are less, they are present in lesser quantity. Okay, so preterm milk, remember the mnemonic, fine sips. F stands for fat, S stands for sodium, I stands for immunoglobulin, P stands for protein, S stands for sugar or calories. Okay, so preterm milk is rich in all these. Okay, and next, feeding, like I told you, no, at beginning part of milk is known as fore milk, so it is thin and watery, so that's why it will satisfy thirst in a baby. Okay, end of the feeding is, we will get this hind milk, so that is thicker and it contains fat, so that's why it will satisfy hunger of the baby. Okay, thirst for, hunger is hind milk. And next, one more very, very important topic for your exam is malnutrition. Like you should know each and every concepts about malnutrition very carefully. So let us discuss about malnutritional aspects in this slide. So remember, malnutrition duration is like two types: acute malnutrition, chronic malnutrition. For acute, for look at the parameter in acute malnutrition, what about weight is decreased. Okay, if the weight is decreased, that is called wasting. Okay, so for weight, what parameter, for wasting, what parameter? Weight for height is used where in acute malnutrition. Very, very important. This been asked in all of your exams. Malnutrition, each and every topic is important. So in chronic, what is decreased? Your height of the baby is decreased. So if the height is decreased, short stature, the short stature, that is known as stunting. No, stunting is a term which is used for chronic malnutrition. Here it is height for age. Height for age chart, weight for height chart is used. Very, very important. Acute, weight for height, wasting, weight is decreased. No, print it in your brain itself now itself, like acute malnutrition, chronic malnutrition. What are all the components are used over here? And if it is moderate, so if I can tell, no, like moderate acute malnutrition. So moderate is the term which is used between, if your value will form between -2 to -3 standard deviation. So if anything, if you want to tell the severe malnutrition, you have to tell the value should be at -3 standard deviation. Okay, -3, it indicates severe malnutrition. Okay, so like weight for age, it is the most commonly used chart. Weight for age. Okay, this is the most commonly useful. If the weight for age, it falls between less than 80% and below, that is known as underweight. Okay, very important whatever I am teaching. So this is used to know both acute, and it is used in the most commonly in acute and chronic malnutrition. What does it indicates? Weight for age, acute and chronic malnutrition. Okay, and next we move on to the severe acute malnutrition. So in severe, when you are going to tell if it is severe acute malnutrition, is edema is present. Acute malnutrition, please remember which parameter is used. Now you guys are going to tell me acute, weight for height, weight for height. Severe, standard deviation how much? Less than -3. No, so that's why I thought the basics. Plus acute, severe acute malnutrition, severe edema, acute malnutrition, weight for height less than -3 standard deviation. This indicates what? Severe wasting. Now your guys are getting, no? And you may find this like a edema, no? Symmetrical edema. So these are all the characteristic features. And what about this mid upper arm circumference? Yes, that should be less than 11.5. And mid upper arm circumference is less than 11.5 centimeters. You are going to tell the baby is having this severe acute malnutrition, edema, weight for height, and your mid upper arm circumference. These all are very important for your exams. Like they'll be frequently asking you. Okay, like these are all the characteristic features of severe acute malnutrition. And types of malnutrition: kwashiorkor and marasmus. So this is also known as kwashiorkor is also known as disadaptive or decompensated. Okay, so what you are finding in this child? Look at this. No, there is an edema in this child. So that's why edema is present. Why? Remember in kwashiorkor, which I am discussing now, it's kwashiorkor. Proteins are less. Proteins are predominantly very less. Deficiency of protein in a baby leads to the kwashiorkor, that to edema. So we all know serum protein is type is serum protein, what it is stored in the body in the form of albumin. No, so if you check the serum albumin, it will be also less. So that's why hypoalbuminemia. No, albumin is also less over here. Protein is also less. Okay, and edema is present. This edema is pitting edema. Proteins is less, edema is less. So this is a very important. So most characteristic feature is your edema. So why edema? Due to this hypoalbuminemia. And how the child will appear, general appearance, how the child is dull, plus lethargic. And what about appetite? Poor appetite. Okay, and what about the face? The face, it looks like a moon face, and it is also known as fat sugar baby. So what I am teaching you, everything are related to kwashiorkor. Okay, and skin changes, you can find this, no, like flaky paint, dermatitis, and like you can also find this enamel spots and crazy pigment dermatitis. These are all the skin changes that you are going to see in kwashiorkor. What about liver? Fatty liver. Okay, and this is about skin changes. And what about hair changes? So you will find this white hair and next gray hair. Look at the baby over here. So black hair, like look at the hair. You can find this black, white, gray, black, and all. No, like in this baby, no. So like that is known as flag sign. So flag sign are patchy pigments. Patchy pigments, that is also known as flag sign. Okay. So these are all the hair changes that you will find in this baby. So what about this, like this baby prognosis is poor prognosis. Okay. So marasmus, they are adaptive and predominantly it is an, look at the baby over here, predominantly it is muscle wasting. So calories are less here. Okay. So main sign here is, there I have thought edema, here is severe wasting, muscle wasting. Okay. So look at the face, it looks like seman face. So look at this, like baggy pant appearance. And look at the baby, how it is. The baby over here is alert and they are having this good appetite. Okay. And outcome is better. Prognosis is good. So these are all. So what about hair? Hair is completely absent in this child or very, very less. So that's why alopecia is also present. Hair loss will occur in this child. Okay. So this is about differences between like marasmus and kwashiorkor, very, very important. And management. So if you come to the management in uncomplicated SAM, so how do you manage? By through the home care. In complicated, you are going to admit the child, that is hospital admission. For how many days you are going to admit? 6 weeks. Okay. So uncomplicated, like no complication is present, baby is everything fine. Okay. In complicated, it is again further divided into two types. One is first week of life, that first week of admission, that is known as stabilization phase, and rest from second to 6 week, that is known as rehabilitation phase. So in stabilization phase, remember iron is not given. So here iron is given. Okay. So and now let's move here, like here what kind of diet? F75. Here F100. F100 feed. F75 feed is given over here. Okay. So like what you are going to give? You are going to, the child is dehydration. Look at this, if the shock is present or not. If the child is having no shock, you can give oral fluids like resomol. And if the child is having shock, what you are going to give? IV fluids. Best is RL in 5% dextrose. So there are a lot of complications in this SAM baby, no dehydration and hypoglycemia. Here there I have thought hypoglycemic cutoff less than 45. Here hypoglycemia cutoff will be less than 54 in SAM babies. Okay. So this is very important. Note down, hypoglycemia is less than 54 in SAM. So you are going to give this vitamin A. So dose of vitamin A in less than 6 months is 50,000 international unit. From 6 months to 1 year, how much vitamin you are going to give? 1 lakh international units. If the baby age is greater than 1 year, you are going to give 2 lakh international units. Okay. So this is about dosage of vitamin A. And this is about which I have completed until now all the general topics, and now we move to one of the very important topic, distress in a newborn. Respiratory distress in a newborn, like if the baby is, this is, look at the chest x-ray, it is like completely white, no? This is known as bilateral white out lung. Look at the x-ray, that is completely white. So this is known as bilateral white out lung, and it is also known as ground glass appearance. And air bronchogram is seen. So these are all chest x-ray signs in newborn who was born for preterm. So respiratory distress is the common cause of distress in preterm babies. So I am talking about preterm distress. Preterm babies, they went to the distress. Then you have to think about RDS or hyaline membrane disorder. It is also called hyaline membrane disorder. Why? What is the common in preterm babies? We know in preterm babies, surfactant is not matured. Surfactant is absent. So what actually happens is, like, most common cause of respiratory distress in a newborn is like decreased surfactant, no? So like decreased surfactant is absent or it is decreased. We all know surfactant. What is the main function of this surfactant? Tell me. Surfactant helps in keeping the alveoli open. If the surfactant, so during expiration, our alveoli, if the surfactant is not produced, alveoli will collapse when during expiration. But here, so this is the main function of the surfactant. If the surfactant is absent, your alveoli will get collapse. Okay. So this is about surfactant. So what are all the types of an surfactant? No, we all know, like lecithin. So surfactant is produced by, tell me, type 2 pneumocytes. No, type 2 pneumocytes will produce this surfactant. Lecithin, it is also known as diphosphatidylcholine. Okay, DPPC. And we all know surfactant, whenever surfactant is less, preterm, RDS. So these are all the X-ray patterns you will see. Surfactant will appear in fetal life. At what week? 20 weeks. Okay. In amniotic fluid, 28 weeks. Mature surfactant greater than 35 weeks. Okay. So here main problem for respiratory distress in a preterm is decreased surfactant. So what is the treatment? Give surfactant to the child. Okay. By how you will give the surfactant? By the intratracheal route. This is the best. And in antenatal period, so you should give this corticosteroids to mother. Okay. So there are two types of corticosteroid, that is beta methasone and dexamethasone. So what is the dosage? 12 mg and 12 mg, two doses, 24 hours apart. And here 6 mg gap 12 hours, 6 mg gap 12 hours, 6 mg gap 12 hours, 6 mg. Okay. So total 4 doses. Here total 4 doses. So D, A, B, C, D, 4 doses. Beta methasone you are going to give 2 doses. B, A, B, second letter. So remember like this. Okay. So this is about respiratory distress. So to assess the respiratory distress in an preterm babies, we will use the score that is known as like Silverman score. So Silverman score is used in preterm babies. So what are all you will find? So upper chest retractions, lower chest retractions, xiphoid retractions, and like nares, nasal flaring, nares dilation, nasal flaring, or grunt. These are the signs you will be seeing in Silverman score. If the score is between 0 to 3, tell me what it is. It is minimal. If the score is between 4 to 6, it is moderately. 4 to 6 is moderate. Greater than 7 is severe. Okay. This is about Silverman Anderson score. And next, transient tachypnea of newborn. Tell me, this is the most common cause of distress in term babies. In preterm RDS, this is in term babies. So this is about the transient tachypnea in a newborn. So what is actually happens is like, no, here what actually happens in this transient tachypnea is, tell me what it is happening. So what it will happen over here is, in fetal lung, fluid is present. So so normally what happens, no, like if the baby is born to normal vaginal delivery, the baby will get compressed. During the compression, like this alveolar fluids and all, no, like alveolar fluids, everything, like what is the fluid that is present in the lungs, whenever they will get compressed, that will come out from the lungs. If the baby is born by in the cesarean section, we all know the baby is not at all compressed over here, not at all compressed over here. So that's why what it actually happens is, tell me, so there will be some amount of fluid is present in the lungs, so that leads to fast breathing, transient tachypnea of a newborn. So this is the over here. So whenever the baby will get compressed, fluid is coming out. No, whenever compression will take place, fluid will come out. That happens in normal vaginal delivery. But over here is like in lower segment cesarean section and all, you can find that the baby is not compressed. So that's why fluid will be present in the alveoli or in the lung itself. So this will be happen over here. So delayed clearance of lung field. Delayed clearance of lung field. Lung fluid. Okay. So what you will find in X-ray? Fluid in the interlobular fissure. So you can find this fluid is present in this interlobular fissures. Okay. So this is then fluid is in the interlobular fissure. So this is the chest X-ray in transient tachypnea of a newborn. So in term neonates, what score is this? Downey score is used. So until now, like these parameters are not, please go through this. No, cyanosis is present, respiratory retractions, grunting, and air entry for Downey score. And most common cause of distress in postterm is meconium aspiration syndrome in postterm babies. Okay, like meconium aspiration syndrome is most common cause of distress in postterm. What actually happens is, imagine this is the trachea and this is the bronchus and this is the bronchioles. Okay, these are all bronchioles. So what actually happens is, this meconium will got struck over here in the bronchi or bronchioles. Air is coming during inspiration, no problem. But while expiration, here meconium is present. Imagine here meconium is, I will zoom in. I will write it very clearly. So these are all bronchi or bronchioles. This red color one is meconium and this is the trachea. From the trachea and all air is coming, but it is entering. During inspiration, no problem. But during expiration, the air cannot come out properly because of this meconium. No, meconium will block the air over here. So that's why on X-ray you will find this hyperinflated lungs. So this is the reason for hyperinflated lungs. Now you guys came know what will be happen over here due to this meconium. Like there is an hyperinflation of lungs. Hyperinflation in the lungs. So this is happening in the postterm babies. So most common cause of distress in postterm baby is meconium aspiration. Three words are very important. Preterm respiratory distress. And I thought you surfactant is less, which is produced by type 2 alveolar pneumocytes. Okay. And like when you come to this term, transient tachypnea of newborn. And you come to postterm, it is meconium. Okay. And next, look at this last, that is congenital diaphragmatic hernia. You can find this abdomen is present in the upper part of the lungs. No, that is known as scaphoid abdomen. Most common form of congenital diaphragmatic hernia, CDH, is nothing but congenital diaphragmatic hernia is Bogdalek. So what is it? Is an anterior defect or posterior defect? This is posterior defect. If they ask side, it is left side. Okay. So scaphoid abdomen is in congenital diaphragmatic hernia. And these are all about distresses and very important general pediatrics. I tried to concise for you with these image, IBQs and all. Very important. Today's session is very important for your exams, like for all of your exams, not only for Norcet and all. So you should know each and every topic over here, like how to treat and how to about these aspects and all. So please go through this very carefully, and please go through this aspects very carefully. It's grams, and like this mg, okay, this is like mg 45, less than 45 mg or grams and all. Okay, fine. Like, and next, these are all about breastfeeding and what are all the topics that I have been covered until now. Thank you for hearing, guys, and keep studying.